Olá, estamos aqui no Congresso Brasileiro de Hematologia, eu, Thaís Fischer, doutora Natalia Zing, Dr. Max Topp, discutindo os últimos avanços em difuso de grandes células B. Dr. Max Topp, we're discussing the last updates on DLBCL, especially the refractory relapse scenario. And since we discuss it a lot these days, can we have like a piece of the data on ZUMA-7?
Sure, it's a pleasure. So ZUMA-7 is one of the three randomized trials in patients with early relapse and refractory aggressive lymphomas. In this particular trial, 380 patients were randomized 1-to-1. The experimental arm was then Axi-cel, whereas the patients which were randomized in the SOC treatment arm received platinum-based chemotherapy plus high-dose therapy in responders. So the event-free survival was the primary endpoint, and most importantly, when you look at the demographics of the patients, which were very balanced, almost everyone which was randomized to Jayascarta or Axi-cel received dose of the experimental treatment, so meaning 94%. Whereas in the arm which were randomized to SOC chemotherapy, only 36% actually reached high-dose chemotherapy. And looking at the event-free survival, there was a marked significant difference in the readout of these patients. And most importantly, was also an overall survival benefit, despite that patients which were randomized to the SOC arm could be treated with Jayascarta or another T-cell product down the road. It still withheld a very high response rate in those patients.
And one thing that is always on my mind, of course, we have problems in access in Brazil. We know that like our time brain to think about the CAR T and receive the CAR T, it's like 4 months and a half. But something that I really like is when not to indicate CAR T. We always discuss when to indicate that it's relapse and refractory and patients will relapse later on and other therapies, but when not to indicate?
Well, it's a very difficult question because the aggressive lymphomas, as you said, some of the patients have very low tumor burden. So obviously those patients we can hold with probably for 3-4 months, and there are patients who have very aggressive disease with an LDH more than 1,000. So to keep them at bay for CAR T-cell therapy is going to be very, very, very difficult. I mean, that's the disease specifics. And then there are also patient-specific questions like poor performance status due to maybe, for example, congestive heart failure or hepatic disease. So like liver cirrhosis might be something that those patients may not be the best candidates for CAR T-cell therapies. But it all comes down to bridging therapy. But then the question back is to me, what are the bridging options that you have in Brazil for these patients?
So we don't have that much. We have clinical trials in some cases, but we have been using a lot of GMOX and radiotherapy because in Brazil, actually, we have two bridging therapies, the holding therapy before we get approved, and then the second, which is truly the bridging therapy. So GMOX plus radiotherapy is an option. But one option that we've been using a lot is Pola R without Benda.
Mm-hmm.
And of course, if the patient has a very high tumor burden, bispecifics can come before CAR T therapy.
And I also have this question about chemoimmunotherapy or target therapy, because mainly in the refractory scenario, the truly refractory patients, even you thinking about to perform the CAR T, do you think there is a role for chemoimmunotherapy before the CAR T, thinking the patient is truly refractory and we don't have any theaters that could indicate that patients will not respond in the second line?
Well, I think that is very important. I mean, the question is, what is refractoriness? Refractoriness means, of course, someone who has no response to chemotherapy, but there's also patients who have a relapse within 3 months, which we would say being refractory to. And I agree with you that those patients are very difficult to be treated with chemotherapy. But as you already said, I think radiotherapy, and this is shown by the British study, can be applied into different areas. So that's, in my mind, a very good option for bridging. And secondly, there seems to be something happening with GMOX to be immune modulatory. So I think this is actually quite a nice combination to integrate radiotherapy plus perhaps chemo in the situation, or chemox in the situation. So I'm not a friend of aggressive chemotherapy like DHAP or GDP because some patients have infectious complications. They may also have renal impairment due to the platinum that we use, and that makes them maybe too sick to receive CAR T-cell therapies.
Exactly. Maybe sometimes chemoimmunotherapy, I think, could impact in the quality of the CAR T, and also could be bad for the patient. You could have more organ damage, more lymphocytopenias, and more complication pre-CAR T or even post-CAR T.
Right, I think where we have clear evidence that bendamustine is definitely an agent that we should not use prior to leukapheresis. It has been shown in mantle cell lymphoma, but also some emerging data in aggressive lymphoma, that the quality of T cells are impaired by bendamustine. So that would be a very good example that you just sort of said, that we also have to be selective on what we have on therapies.
And also infections, as you said, is something that could stop us from giving the CARs.
To receive the CAR T after the apheresis.
And to close this discussion that was very productive, and thank you again for this participation. I think it's really important to emphasize that the patient can give us signs that he's not doing well. For example, with PET entering positive, meaning PET 2 in Brazil, we used to do PET after the third cycle. Actually, it's not common to do after 2 cycles. It's more common to do 3 or 4. And we usually don't have like 2 PETs as the study was presented. But it's a red flag showing that maybe this is the patient that we should refer early to a CAR T center.
And
so
something
different.
And also in that regard, I mean, the emerging data with freed tumor DNA, it speaks to the same situation. I mean, that will probably be integrating our algorithms down the road to use that kind of DNA measurement of the different patients that are actually at risk of relapsing, and then giving them the CAR T-cell option early onwards.
And maybe in the future we can personalize even better, like give the right treatment to everyone.
So thanks again.
Thank you again.
For this great opportunity. And take a coffee with us.